So in this session, actually, I was supposed to talk on some iliac dissections, a case-based presentation, and how to manage. So actually, I'll show you a case. I'll share a case with you, which is a iliac complication case in Tower, and how we did that and what all happened. So this is actually in our initial experience of Tower when we were using much bigger sheets. I'll explain you all that. So it was a 68-year-old male with symptomatic aortic stenosis, NYHA class 3, with exertional dyspnea, no history of CVA, CAD, or peripheral arterial disease. He had sclerodegenerative AS with moderate MR secondary to LV dysfunction, and the EF was about 34%. And the peak gradient was 89 with a mean gradient of 47, mild PAH, and the STS score calculated was 8. So that was the CT picture. If you see tricuspid valve, when you have calcium chunks on at least 2 leaflets. And measurements wise, the annulus, perimeter derived annulus was 27.3, and the area derived was 26.7. So with that 26 to 27, the valve advocated was a balloon expandable in this case that we used, a Merrill 29 millimeter. And the Merrill valves during that time did not have the Python sheath. So the sheath size for this 29 millimeter valve was 24 French. And that was the peripheral angio, as you see. Well, it looked not bad, but yes, this measurement in the middle part of the iliac vessel was 5.9 to 7, which is somewhat smaller for that 24 French, I understand and agree. But there was no calcium, and it was a straight vessel, and the operators who were there felt, well, we can probably do it. So with that, we went ahead and planned the case. And there was some slight resistance in advancing the sheath, the 24 French sheath, but it went in without any major difficulties. So that was fine at that stage. And the procedure was also could be conducted reasonably well. Oh, sorry, this doesn't move. I think it doesn't have the loops there. So anyhow, so this is so we don't have the loops. The valve in position, and this is the inflated valve, and that was fine. So that was the end of the implant, and that was okay. But post-implant, there was extreme resistance in sheath removal, which suddenly gave way, and finally the sheath came out, but that was at the end of the procedure. But no later, the BP showed an immediate drop. And when we saw what was in the hand, this is what was there in the hand. You see the sheath was covered with with a part of the artery. And the right iliac artery had actually avulsed during retrieval of the sheath with profuse bleeding and hemorrhagic shock, and the BP sank to 40-50 systolic. So the first thing that we did was immediately a peripheral balloon was advanced on the same wire through which it had come out and inflated to cause balloon tamponade of the rupture, and concomitantly blood arrange and hemaxil infusion started. So you see the balloon is inflated there. I wonder if this will not run. I'm sorry about it because of the snags that happened in between. Anyhow, so that was the balloon tamponade. And with that, the pressures started slightly maintained. And then there was a transient deflation that we tried for an angiogram to see where the leak is and what is happening. And it showed the massive leak from the common iliac artery, you see. So that is where it was a big leak. In fact, there was probably a segment of artery that had totally gone off, and the link was only the wire. So it was good that we had the wire across. So balloon tamponade maintained while arranging for a covered stent. So by the time the covered stent would come, we had the balloon tamponade again. And the covered stent was then deployed, but the pressure continued to fall. So again, some balloon tamponade was done. So we deployed the stent, but probably we were missing the real site of bleed. So we needed some multiple covered stents, and then a second covered stent was deployed, but still pressure continued to drop. And I think if you see here in the picture, in the hurry, you see, sometimes it happens. We miss the overlapping point, and so it continued to leak probably. And then balloon was deflated and check angio done, and there was a small leak still continuing from the in between part. I'm sorry, I cannot run these otherwise. So more balloon tamponade done, and then a third covered stent in the in-between segment between the distal and the proximal. So we had, and this is the uncovered part. If you see, the first stent is ending here, and the second is starting here. So we had a third stent placed there. It was good that we had the covered stents, multiple of them, and then the check angio with the inflated balloon and then with deflated balloon. So it showed that it is all paid. There's no leak anymore. So there was no leak, but then actually all this time we were compressing because the big sheath had already come out, and we were managing this through a smaller, just through the wire. So we were compressing this all the time. And then when we checked the angiogram, the flow was not going down. I today on the hindsight still wonder that this was probably not going down because I was compressing it. We were compressing it hard so that it doesn't bleed from the groin. But anyhow, at that time, the team decision was that probably there is a thrombus here because of, and that's why the distal runoff is not happening. And then we had to do emergency fem-fem bypass done to the right common femoral by the vascular surgeon. And 3 to 4 hours post this bypass procedure, the patient complained of right lower limb pain with absent pulse and closed extremities. In fact, the graph that was put, there was some clotting in the system, and the surgical re-exploration and embolectomy was done with, again, good distal flow. And the patient was then successfully discharged after 3 to 4 days. So post-discharge at 15 days, patient unfortunately presented again with a local wound site infection. Now, so that had healed, everything was done, but the surgical wound that was created because of the fem-fem bypass and the embolectomy, that had some infection, and then plastic surgeons were roped in, and they had to do some skin grafting, and then that had to be repeated. And that is the horrific picture we ended up with after all the skin grafting and everything. So this is the groin. So that was very bad, I would say. That was horrific. And then after about 6 weeks of hospitalization with multiple grafts, and there's all plastic surgery were going on, still pretty bad. And the hospital stay for this patient was nearly 2 months. But finally, the good part was that it was a successful recovery. So this is how it healed after about 2 to 2.5 months. This is how it looked. So that had healed. So friends, the learning messages and the iliac, you have to be very careful of this iliacs. It was good that I had this in my initial part of experience. This case is about 3.5, 4 years old, if I'm not wrong. 4 years, more than 4 years old, I think. Vascular access site complications, not uncommon with large size delivery sheets used in tower, but now the delivery sheets have come down. We don't use 24, 22 French anymore. Even for the Merrill valve, they have come down to 14 and 18 French with the Python sheet. A very good assessment of the iliac artery size must be done, and it must be respected. Never exceed a sheath external diameter to artery diameter of maximum 1.1:1. And balloon, and you have to be more careful if there is calcium. Balloon tamponade is the immediate life-saving step in cases of major iliac dissections, leaks, or ruptures. And covered peripheral stents are a must in your inventory if you're doing tower. And it's only the covered stent that salvaged the whole story then. Thank you.